you. That
makes it easier, right?
simplifies things a little bit. Yeah.
Yeah. So Leith is actually a name. There's a car company called Leith in Raleigh, North Carolina, and in central North Carolina. So everybody always asks me if I'm a member of that car family. And so I always say, well, if I was a member of that car family, I'd probably be selling cars right now instead of doing what I'm doing. So it makes it easier for me to just go by Gray. Anyhow, you let me know when I can start.
I think we're ready to begin now. Again, everyone, thank you for joining us live on Facebook and through Zoom to our live Q&A expert session with Dr. Linda Gray from Duke University Hospital and the Duke University Faculty of Medicine. On behalf of everyone from the Spinal CSF League Organization of Canada, we want to thank you, Dr. Gray, for being so generous with your time today. And for those attending, again, via Zoom and Facebook through the live feed, thank you for being here. And just before we begin very quickly, we thank everyone for the questions they submitted ahead of time. And we were, in fact, overwhelmed with a vast number of questions. So we're going to get to as many questions as we can today, so that perhaps even we can receive some questions in real time through the chat function. But I'll just get right into the questions, Dr. Gray, if that's all right with you.
Sure.
Our first question comes from Jolene. I would like to know, under what circumstances is it helpful to have a DSM performed to assist with locating a spinal CSF leak?
Okay, well, let me first start by saying thank you for the invitation to speak to all of you today. I know this is the Canadian Leak Week organization. I hope all of you are doing well in this time of COVID and staying well and isolating. And I hope, you and your family and yourselves stay safe. Because even though, a lot of you may have cerebral spinal fluid leaks, COVID is a pretty bad thing too. I'm a member of the Medical Advisory Board of the Canadian Spinal CSF Leak Foundation, so I just want to let you know that as well. We see a number of patients from Canada, and I think that a more robust program in Canada is needed across the country so that you guys don't all have to fly down to Duke. Or to Cedars-Sinai or Mayo Clinic or wherever. But anyway, let me answer the first question. When do you want to have a DSM performed? DSMs are really great if you're looking for a fast leak. So it turns out that probably leaks have different speeds, and we never know exactly when we see a patient, we don't always know whether they have a fast leak or a slow leak. Sometimes if you have an MR scan ahead of time, you can actually see a leak on the MR scan, and then in all likelihood, you're probably dealing with a fast leak, in which case a DSM is going to be the best thing to do. You can do that with an ultra-fast CT scan as well, so you don't just have to do a digital subtraction myelogram. A digital subtraction myelogram is putting in the contrast while you're under fluoroscopy, and then just really imaging imaging really fast with a subtracted image. So you take off all the bones that can impede your ability to see a leak, and then you can see the contrast actually leaking out. A lot of times these are done under general anesthesia because you have to have the patient really still, and you have to suspend respirations when you do that. So at any rate, that is what a DSM is, and it's a really good study for a really fast leak. Also, if you've had hardware before, sometimes any kind of back surgery where you've had hardware can also impede the ability to see cerebral spinal fluid leaks, and another good time to do a DSM. So that would be it. Okay.
Thank you. The next question comes from Leanne, who asks, how reliable or safe are CT myelograms and DSMs at less experienced centers where they're doing these tests only a handful of times per year?
Okay. So, my feeling is at this point, we know a lot more about cerebral spinal fluid leaks than we did in the past. Originally, I think a lot of people felt like leaks were coming from cysts. And then we kind of got off the cysts when we discovered that they were fistulas, and now everybody's onto fistulas. but they can also occur underlying discs or underlying facet joints. And who knows, there may be other causes that we haven't thought of yet. So I would say that you probably need to go to a center where they are really dedicated to finding leaks, particularly if you have one. A lot of times myelograms are done in a fluoroscopic suite. They put in the contrast, then they put you on a gurney, you travel over to the CT scanner, and they get 2.5 millimeter thick slices. In that time where you've gone from the fluoro unit to the CT scanner, you've lost a lot of information because there's been 30 minutes before you've gotten on the table and gotten the imaging. They will generally scan you on your back. My feeling is that a lot of patients need to be scanned prone because the leaks are usually ventral in location. They're coming out of nerve root sleeves or from discs along the ventral surface of the dural sac. So yeah, I think a lot of times they should be done prone. Then you need to do them very thin. So you have to get a helical kind of imaging so that you generate 0.5 or 0.625 millimeter thick slices. A lot of imaging that we get in from the outside are, amazingly enough, 2.5 millimeters is a thick slice when you're looking for a leak, okay? It's small, but it's a thick slice if you're looking for a leak. So you need as thin a slices as you possibly can, and you need to get imaging as quickly as you can. Then, ultimately you may want to go on to something that is a delayed imaging, like an MR myelogram, or maybe even a nuclear medicine study. But at any rate, I think you need to go to a center where they know what they're doing. And more centers are getting involved. So there's people up in New York and Utah and UT Southwestern and Cincinnati. So more people across the country are getting involved in the whole workup of people with CSF leaks, which I am gratified by. I think it's super important because I think a lot of migraine headaches are possibly pressure-related problems. Not all leaks, but they may be pressure-related problems. Okay. I better quit talking. We won't get through these questions. Okay, go ahead.
Further to your point on fistulas, I'll jump to a question from Lauren. What causes spontaneous venous fistulas?
Yeah, wouldn't that be a great idea to know that? I don't think we don't know, okay, is the bottom line. We really don't know. But let me just give you one of my my hypotheses, or one of the things I have thought about. I wonder if they're not a high pressure person presenting with low pressure. So let me give you an example. I had a patient who was doing mama baby yoga. And in mama baby yoga, she all of a sudden developed a like a positional headache. She came to us. She had a cerebral spinal fluid fistula. And since she'd come from quite a distance, we said, well, why don't we just get you fixed? So we had her operated on later on that week, fixed the fistula, and she immediately went into high pressure. Such high pressure that she ultimately wound up needing a shunt because no medication could control that high pressure. So in that case, I wonder if she wasn't always kind of a high pressure person. She blew out through this fistula, and then the fistula got repaired, and now she's in high pressure. A lot of people with high pressure will get leaking at the base of the skull. So people with kind of chronic high pressure can also leak through their ears. And those are ways that you decompress a high pressure system. So I'm wondering if fistulas may not also be a pop off for a higher pressure system. Possible. There may be other causes. Maybe there's erosion of the like degenerative changes of the spine that maybe erode a nerve root sleeve and a vein. There could be fistulas because ventrally it may be a disc, could actually penetrate the dura and adjacent vein, and then you could get a fistula in that regard. So there's probably multiple causes, but one of them might be high pressure, and then these other degenerative changes might cause fistulas as well. What's next?
Question from Don. What type of needle should be used for CT myelography to prevent a puncture?
Yeah. So, one of the patients a long time ago actually turned me on to the Gertie Marks needle, which is a 24 gauge blunt tip side hole needle with a much lower incidence of having a post lumbar puncture leak. So in general, I feel like, you should try and use as small as needle as possible. Now, that's not always done. A lot of people use 22 gauge spinal needles. Certainly you do not want to use an 18 gauge spinal needle, or really, I would hope that you could avoid a 20 gauge spinal needle, but I can't dictate how people do things. But I think the smaller needle is better. One of the issues, like with doing DSMs, is you need to be able to push the contrast quickly, and you can't do that through a 24 gauge needle. But in the initial workup of the patient, I think it would be helpful to use a smaller needle as possible, particularly if you don't know the patient is really in low pressure when you first see them. So yeah, I think as small as you can go, depending on what you need to do. For DSMs, they need bigger needles sometimes. I get that. So you have to go up a little bit in your caliber size, but then hopefully you can patch that site as well.
Thank you. That's certainly very, very helpful information for our medical community here in Canada. So thank you. The next question comes from Brandy. What other procedures are available if a patient is highly allergic to the fibrin glue besides blood-only patch? And it seems as though what happened was anaphylaxis from the last patch in this case.
Right. That is, we've had sort of anaphylactic reactions happen 4 times here. And, people did okay. We had to send them to the emergency department. They needed steroids and Benadryl and things like that. But right now, there is not another fibrin glue on the market. Now, one of the things that might be considered, I just don't know how well they'll work, are using stem cells or something like that, but there's just no data on that, whether any of these other kind of products that are coming out might be helpful. Some people just tend to be have allergic kind of physiognomy, and we have people who will react to contrast and get anaphylactic reactions. Sometimes they are just hypersensitive people. So it depends, like if this person happens to be hypersensitive to many things, you may have to just really pre-treat them with steroids and Benadryl in order to avoid that, and just have anesthesia standing by in the event that they do have an anaphylactic reaction. But I don't have an answer for that right now, but there are definitely other things that could be considered.
Great. The next, thank you very much. The next question comes from Christina Marie on the issue of Chiari versus CSF leaks. Can you distinguish congenital Chiari from acquired Chiari due to a leak on a brain MRI?
Yeah.
Most radiologists call it Chiari. Those symptoms didn't appear until after a lumbar puncture.
Yeah. So that is such a great discussion to have. Lots of patients have quote unquote Chiari 1 malformations. And there is a differential for that, actually. So some people, one of the causes of a real Chiari malformation is a small posterior fossa, which is, sometimes hard to determine, sometimes not. But people with high pressure, about a third of the time, can present with a Chiari malformation or, tonsillar dissension as a consequence of their high pressure. So high pressure people can have it, people with small posterior fossas, and obviously, as many of you know, people with low pressure can have tonsillar ectopia or low-lying tonsils. There are other things to look for if you're considering low pressure as a cause, and that would be sometimes there's a sloping of the third ventricle. The mammillary bodies will be more tightly, could be more tightly adjacent to the pons. So there are other features to look for if you're thinking intracranial hypotension, and there are other things to try and distinguish it from hypertension. So for instance, in hypertension, the pituitary fossa may be scooped out, and patients can have what's called a partially empty sella, whereas patients with low intracranial pressure may have a swollen pituitary gland, which is common. So it's pituitary hyperemia as a consequence of the venous engorgement that happens with SIH. So there are different ways to tell, but I agree with you. A lot of people just throw it all in one basket and say, you know, that patient has a Chiari without really trying to dissect out, is it a small posterior fossa? Is this really intracranial hypertension, or is it intracranial hypotension? So I have a whole bunch of cases where that has come up. I actually have sent a patient for Chiari decompression who actually that was their problem. They got sent to me with a Chiari malformation. We worked it up. It wasn't high pressure, wasn't low pressure, and we treated them in both directions, and ultimately they got a Chiari decompression and they're doing great. So yeah, so there is a differential of those three things: SIH, IIH, and then a real true Chiari due to a small posterior fossa. Important to distinguish all three of those.
Thank you. I think that quite highlights how this is a condition that's often misdiagnosed and perhaps even chronically misdiagnosed.
Yeah.
Thank you, Dr. Gray. For those of you just joining us live on the Facebook feed or through Zoom, welcome to our Q&A expert session with Dr. Linda Gray from Duke University Hospital and the Faculty of Medicine there. The session is brought to you by the Spinal CSF League Organization of Canada. And thank you again for joining us. I'll move on to the next question, Dr. Gray, from Krista. How often should imaging be done if you still have symptoms of a leak, but you have never been offered any treatment except migraine medications because imaging is not showing a leak?
Okay, so I'm going to presume that the imaging that was done was actually an MR scan of the brain that did not show signs of having a leak. And you know what? I mean, it's so common to have normal brain imaging and still have a leak. I had somebody who came to me from Europe, and she actually had a diffuse leak and just a super normal looking MR scan. So you can have a normal brain MRI and still have a leak. So I think it's still important to just consider, is this a pressure related problem? So how can you figure that out possibly? If you put yourself in sort of a Trendelenburg, like feet up, head down, and you know, you can even get something like an inversion table or you know, create something like an inversion table, and your head feels better when you lie down than when your head's down and your feet are up, then it would be worthwhile to consider that this might be a low pressure problem. So let's talk about for 1 second, what causes positional headaches? And I think about three things when I see patients. It could be a low pressure problem. Even high pressure can present with positional headaches, and it can be a cervicogenic cause. So if you have some kind of degenerative changes of the cervical spine, that can also give you positional headaches. So what are some other things you could do? If you put on an abdominal binder and, you know, really tighten it up, that will make a high pressure problem worse and should make a low pressure problem better in general. So you can try something like that. People who go to the mountains, so if you wanted to take a trip and go to the mountains, people with high pressure typically feel worse in the mountains, and people with low pressure tend to feel better. So that's another way, is just changing your atmospheric pressure can help to figure that out sometimes.
That's interesting. Thank you. The next question is from Fadia, who asks, what type of testing is recommended for a long-term rebound patient? Do you recommend MRV testing? And I suppose you could explain what MRV testing is.
Okay, so MRV is an MR venogram. In general, unless you're doing a contrast-enhanced coronal imaging through the venous sinuses or axial imaging through the venous sinuses, MRVs are just fraught with artifact, and there's a lot of it oftentimes raises more questions than it answers. I personally love CT venograms. CT venograms are great for evaluating, and what are you looking for? You're looking for, are there any things that look like there are areas of narrowing in the sinuses that might be causing increased pressure? Treating rebound high pressure, boy, that can be really tough. And I've had to deal with a couple of people with that. One of the things I have done is done a couple of lumbar punctures in a row and just taken off a bunch of fluid. So sometimes I'll take off fluid a couple of days in a week, like a Monday and a Friday, or Monday, Wednesday, Friday, and take off 20 cc's. And sometimes that can help to reset the patient. Sometimes people who are stuck in rebound high pressure may have been high pressure people who blew out, and their real problem is high pressure. You saw them with low pressure, you treated the low pressure, now you have to deal with the high pressure. So sometimes it is that as well. So I would, the rebound high pressure, if you can't treat it with drugs, it can be complicated. Like that patient I told you about with the fistula who ultimately wound up needing a shunt. I have had a couple of people who wound up needing shunts, and you don't like to go in that direction because shunts have their own problems. They can get infected and kink, and oh my gosh, I hate putting shunts in people. So that's something that you want to do. Really, that's like the extreme. You don't want to do that if you can avoid it.
Just a very quick follow-up question on that, on a point you raised there. This is from Jen. Do the lumbar puncture, or the lumbar puncture method you just described, is that just or the drainage rather, does that have a long-term effect, or is it just kind of a
temporary?
Yeah.
Temporary. Yeah. So actually, it can reset people in some ways. So I've taken off fluid off of people a few days in a row, and it resets them, and they're better. I had a guy actually in Wisconsin who got his leak got fixed, and then he went into rebound high pressure, and I just had CSF taken off like a couple of times in a row, and he got better. Somebody did it for him up in Wisconsin, and he got better, and now he's fine. So, that's a problem that, there's no great data on, and you just have to figure out when it comes up. And I don't think that everybody has, we don't have like an established way to work that up or to help people with that, but hopefully drugs help in the majority of cases.
Yeah, hopefully there'll be more research on that point to come.
Yes.
We still have time for a few more questions, Dr. Gray?
Yep.
Okay, thanks everyone again online just joining us. We're in our Q&A expert session with Dr. Linda Gray from Duke University. The next question came to us in real time from Mary, who asks, what period is required for repeat blood patch? And I take that to mean what period of time between blood patches?
Okay. So in general, blood breaks down at around 2 to 3 weeks. Fibrin glue is a little bit longer, so like maybe 3 to 4 weeks. So you could probably repeat the patch after that time, but hopefully you would want to be getting better. And I guess the question I would ask Mary is, was it after a lumbar puncture, or why did she need a repeat one? Or was it a disc penetrating the dura? I mean, those things can, things that make a difference is why did the leak occur to begin with? So let's say the leak was due to a disc that was penetrating the dura. Well, if her leak came back, in 3 to 4 weeks, I might patch her one more time and then set her up to see a surgeon, because my patch is not going to last in that particular instance. So if you have a disc penetrating the dura, that is like a sharp object, and you are not going to fix that problem. In all likelihood. That's not entirely true. I had somebody who came from the mountains of North Carolina with a spike in the dura, and I patched her one time with fibrin glue and blood, and that was it, and she was fine. But I saw her within 12 days of symptoms. So it may be that if you see people sooner, that you can actually fix the problem better with fibrin glue and blood. Some people who have been suffering for years, if that disc is there, it is going to make a really well-worn hole in that dura, and you are unlikely to fix that problem. So in that case, that kind of leak is going to need to be fixed surgically. So as far as whether, how soon to repeat the blood patch, it kind of depends on what you think the problem is. So you can do it though within 3 to 4 weeks, probably after the patch.
Thank you. We're getting a lot of questions. We received a lot of questions rather about barometric pressure, and this one from Natalie I think sums it up. Can you please clarify how CSF leaks interact with the higher the higher and lowering of barometric pressure outdoors? When a storm is approaching, my head can feel it before the storm arrives. Usually a day ahead of time, I begin to feel miserable. When the barometric pressure drops below 30, does that put you into a high pressure or a low pressure situation?
That is, I would like to know the answer to that myself. I will tell you that people who have high and low pressure problems respond to barometric pressure differences. And, some people with intracranial hypertension, when the barometric pressure goes high, they feel worse. When the barometric pressure goes low, some people feel worse. So I don't think we really know which direction it goes. Sometimes what I think is it's just the change in pressure that people are really sensitive to. So it may not be the number per se or what direction it's going, but actually the change itself. I think that, people with high and low pressure probably have their baroreceptors throughout the body. And I bet you those baroreceptors in people who have pressure-related problems may be more hypersensitive. So they're just more sensitive to barometric pressure changes. It may be that, people whose headaches respond to barometric pressure changes, maybe that's an indicator that actually they have a pressure-related problem, possibly. I've wondered about that. So, another area for research, I would say. There's a guy, Alan Finkel, who's done a lot of work on barometric pressure changes. He's written some articles about this. And also Vince Martin, who is a headache specialist, has written about barometric pressure changes and migraine headaches. But I wanted to work with both of those guys and see how many of those people actually have high or low pressure problems. So did that answer that question? Because the answer is probably either direction, people will feel symptoms. Now, let me just say, we did talk about barometric pressure changes before. People, again, if you go to the mountains, people with low pressure problems tend to feel better in the mountains, and people with high pressure problems tend to feel worse. So you could always figure out your problem, or even in airplanes sometimes. People who fly with high pressure oftentimes feel worse, whereas people with low pressure tend to feel better. None of us are taking airplane rides right now, but in the future, you could always check that out too.
No, that's so true. We do receive a lot of those accounts from patients who interact with us. The next question is from Katie, kind of a two-part question. First, I'm wondering how high up a fibrin glue patch can be done. And second, and more generally, I'd also like to hear a bit more about the treatment and success rate provided at Duke.
Okay, so the fibrin glue patches can be done all the way up to base of skull. So anywhere along the spinal axis, we can actually put in fibrin glue. The higher up you go, you're going to use smaller volumes, but and typically at the C1-2 level, there's a big space there, but you can still patch there. So you can patch all the way up to the base of skull, essentially. You can't do anything, we don't do any intracranial work. Okay, so what is our success rate at Duke? I cannot tell you exactly the answer to that question because there are 4 of us doing cases and we are pooling that. We're now, we have a research coordinator. We follow up all of our patients. Pretty soon we're going to have 850 patients that are enrolled in this study. And then I'll be able to tell you what the success rate is with at least the procedures that we're doing. So I can't give you that information yet, but I can tell you that we are definitely collecting that information. And at some point in the future, I'll be able to tell you how it is. So yeah, I don't know the answer to that yet.
Well, anecdotally, I suppose it's a pretty good success rate because more and more we're seeing Canadians being referred to Duke University with this.
Yeah, I mean, listen, I've helped people solve a lot of problems, no question about it. And some of the cases have been super interesting. And I've learned, it's funny, the more I work with people, I actually learn from all of you. I learn from all the patients that I take care of because each person is going to be a little bit different. So from one patient who came to me from Canada, I learned that you can have kind of a spongy kind of CSF fistula that just absorbs the cerebral spinal fluid like a sponge. It's going to be a kind of a slow leak in a way. And this patient had terrible problems, but has gotten better and had to have surgeries and repeat surgeries because this spongy stuff is kind of up and down the spinal axis on him. So at any rate, I learn a lot from you guys. And so each person that, we work with, we just really try and figure out the problem and work out where the leak is. And sometimes you can't figure it out right away. So we appreciate when you guys are willing to hang with us and work with us until we can figure out your problem, because obviously it's a relatively new area in terms of medicine, and it's kind of a team effort, us and you working together to figure out where the leak is and how to fix it effectively and make you better. So anyway.
Well, I can say firsthand that we've benefited from your work and your team's work and the treatment options that you provide at Duke. So thank you.
Yeah.
And our dream, our goal is really to have something similar in Canada one day.
Yeah. And you need it across the country. I mean, one center in Canada is not going to be able to service all the patients that are going to need help. So you really need people across the country. It's kind of like, we have somebody in Rochester, Minnesota, that's kind of mid, and then Cedars-Sinai and Cincinnati and Dallas and North Carolina. And now there's people up in New York doing cases. And, I think probably every province in Canada needs to have somebody who works on this problem. And just like I feel like every state in the country needs somebody, I just think it's way bigger problem than people are recognizing.
Yeah.
Yeah.
Thank you again. Here's another interesting question from Natalie. How can you tell the difference between high and low pressure?
Okay, so we kind of addressed that a little bit. So, as I said, if you put yourself with your head down and your feet up and your head feels a lot better and you have to spend a lot of time in Trendelenburg, kind of that's that position, then it may be that you're a low pressure person. This is if you haven't had imaging that actually documents one way or the other, because there are imaging findings on MR brain studies that can indicate maybe whether you're a high or low pressure person. That being said, sometimes I will see high pressure people who present with low pressure, and you have to treat the low pressure and fix the leak, but then you have to treat the high pressure. So some people can be high pressure, blowout, and you see them with low pressure. So, so how to figure out whether you are a high or low pressure person? That abdominal binder thing can help. Taking a trip to the mountains might help. So some of those features, you can always do a trial of Diamox or Topamax. Topamax and Diamox both have like what's called acetazolamide, and they will tend to reduce cerebral spinal fluid production. So if you do a trial of that, assuming that you can take that medication, and some people can't, but a lot of people can. If you do a trial of that and it makes you feel better, then you might be a high pressure person. And if it makes you feel worse, you might be a low pressure person. Acetazolamide is a drug that people take when they're climbing Mount Kilimanjaro. And so it's a drug that you can start quickly and end quickly without too much of a side effect. So it's not something you have to ramp up and then ramp back. The one thing about Diamox too is that it doesn't give you a lot of cognitive issues as sometimes Topamax can. So, but you can also try Topamax. I mean, that requires a little bit more of a ramp up. At least I know a lot of neurologists will ramp that up as opposed to just giving you a dose that might have an effect. So sometimes you have to ramp it up, but still worth trying either one of those. Topamax in general is going to make a high pressure person feel better and will make a low pressure person feel worse.
Is there time for 2 more questions, Dr. Gray?
Yeah.
Okay. So from Connie, do any of your confirmed leak patients accurately feel the location of their leak in the spine?
Oh boy, I love that question. I think sometimes people do. Okay. And I think that sometimes if the leak happens to be due to a disc, it can actually, you could feel where that disc is located. Now, sometimes people want to tell me that their leak is up in their neck because they have neck pain. And in that case, that's generally not true, because some of the symptoms of intracranial hypotension are, besides a positional headache, you get neck pain going down the back of your neck and into your shoulders and in between your scapula. And so sometimes that is, your leak is not up in your neck because you feel the pain up there. It's just like the leak is not in your head because you feel the pain up there. But I think sometimes people do feel that. And I think maybe when people say, I think, that's what I feel when, like if I'm putting needles in there and I'm patching there and they say, that's what I feel when I get my leak. Oftentimes I'm looking to see, like, are there degenerative facet joints that are actually causing that pain, or is there a disc, or is there something affecting the nerve root sleeves at that level that might be causing it? So yeah, I can imagine that sometimes in those particular instances, you might actually feel the pain where the leak is occurring.
Thank you. So we'll wrap it up with a question, which I think is a good one to conclude with, because it touches on Canadian content, and there are multiple parts to it, so we can break it down as you go.
Okay.
But it's from Mark. Do you see or treat many Canadian patients? Are they usually referred to you by a Canadian physician? In what circumstances is a Canadian patient referred to you? Which part of Canada are your patients from mostly?
Okay. So our patients have been from across the country. So yeah, across the country. So there's been no particular area that we get them from. A lot of times I think that, sometimes patients will contact us from Canada, and we definitely will take self-referrals. We got to the point at one point where we had so many patients that we were just taking patients who were referred from their physicians because we were just inundated. But hopefully we're working through that. And as COVID, as we start seeing more and more patients, as we kind of relax our situation here at Duke, and letting more patients in, right now we're not seeing international patients. I don't really see Canada as being international, but right now a lot of the health system is not seeing Canadian patients because they're not seeing international patients. So I usually don't think of Canada as international because, we're right next door to each other. But anyway, so that being said, a lot of times we do get referrals from neurologists and neurosurgeons up in Canada who will send patients to see us. But we have also seen patients who are self-referrals, and we see any one of those. So yeah, because we realize that sometimes people are symptomatic, and physicians don't necessarily recognize their problem as potentially a low CSF pressure problem. So we definitely will see patients who are self-referrals.
Well, Dr. Gray, on behalf of the Canadian Spinal CSF League organization, I want to extend a very big thank you to you. We're really grateful for you being so generous with your time. It means a lot to us. I can say with confidence, it means a lot to those that are attending through Zoom and Facebook. It's always uplifting to hear from, or to have an opportunity to hear from, a world-renowned expert. And you touched on this point earlier, where, ideally in Canada, we would have a vast kind of network of centers that could help these patients, rather than kind of a patchwork, which is what we have now. And so we look to people like you, to professionals like you and your colleagues in your center as Duke, really as a guide for us here. And in a perfect world, we would have a network of those centers across the country. And that's certainly what we're working towards. That's our goal, to have a homogeneous kind of network that can address all these things. But above all, we just want to say a very big thank you to you on behalf of the organization and everyone in attendance.
Yeah, you guys, you all stay well, and I look forward to seeing some of you maybe in the future. Bye. Take care.
Thank you.
Yeah.
Thank you, Dr. Gray.
No problem. Nice to see everyone. Bye.